Joe, do you hear us?
Yeah, yes. We can actually hear you. Good morning. Who is that? Is that Andras?
Good morning. Good morning. This is Andras here. To see you and to hear you.
So you can actually see us. Very good. I hope you've had a good evening last night, and we're in this lovely seaside city of Massa, which is the Tuscany Center for Pediatric Cardiology and Cardiac Surgery. And I'm with Isabella Spadoni and with Cataldo, who is one of the adult cardiologists who's been with us doing the case this morning. So Isabella will introduce the team, and then we'll introduce the patient for you.
So good morning, everybody. Thank you very much to Mario to give us this opportunity to participate to this extraordinary meeting. Let me introduce our cath lab. Here beside me, of course, our friend Joe. It's a pleasure and honor every time to work with him. Cataldo Palmieri, Joe has already said. Vittoria De Lucia, my colleague. Mauro Mantegazza, the nurse. And Monica, the Menconi, the nurse, and Angelica Glunder, who is the radiological technician. So Alessia Lunardini, we have also the anesthetist, Sasha Morozan, and Slavic, who is the anesthesiology technician. So Alessia Lunardini, my colleague, will introduce the case. Fate vedere per favore le diapositive.
Can you show the details of the case? Please.
Please. Here they are, Alessia.
This is our first case, a 36-year-old male patient with diagnosis of requartation.
Can they hear her?
Alessia? Can you speak a bit louder because we do not hear you?
Can you speak louder, Alessia?
Okay. He was operated at the age of 2 years with the hand-to-hand anastomosis and PDA closure.
Can you hear her or not?
Yes, now it's okay.
Thank you.
In adulthood, diagnosis of recortation was made. The patient had the systemic hypertension and was put on therapy with beta blockers and ACE inhibitors. The body weight is 76 kilograms. He has a 2/6 posterior systolic murmur. Femoral pulses are mildly reduced, and there is a 10 millimeters pressure gradient between the upper and lower limbs. On echocardiography and cardiac MRI, we can notice a hypertrophic but well-functioning left ventricle. Aortic valve is bicuspid but normal functioning. Ascending aorta is mildly dilated, and there is a isthmic requartation. The patient underwent stress echocardiography and therapy with beta blockers. Blood pressure was elevated at rest and became even more elevated with the exercise. There were no exercise-induced arrhythmias, and the velocity at the isthmus level significantly increased, and the diastolic runoff became more evident. Here you can see the narrowing at the isthmus and the increased velocity of flow. The dimension of the aorta measured at the CMR are 20 per 18 millimeters at the level of the arch, 12 per 12 millimeters at the level of the stenosis, and 28 per 29 millimeters in the post-quartation segment. The length is about 31 to 35 millimeters. The intended procedure is stent implantation in quartation.
Thank you, Alessia. Can we have, please, the angiography? Please, the first one.
Before that.
Okay, Joe.
Yes, okay, so can you, before that?
Before, the first one.
Prima prima di questa?
Prima, la prima. Okay.
See. Okay. So can you see that picture? What we've done is we've had a look at the groin.
We don't.
You can't see that. Can you see the fluoro picture then? Can we show them the fluoro picture?
We need to see fluoro.
You can, fine. So what we've done is we've just put a needle on the surface to see where we're going to do the puncture.
Okay.
This patient is very fit and not overweight, but if you have an overweight patient, the inguinal crease tends to drop down, and therefore it's very difficult to know where to make the puncture site. So looking at your needle in relation to the femoral head is very, very important, and we generally try to puncture between the lower third and the upper two-thirds of the femoral head. Obviously in coarctation, which is what this patient has, you may not have very good femoral pulses. If you need to use ultrasound to get into the femoral artery, that's fine. It's important to do it safely. We knew that we were going to use a large French sheath, which is a 14 French sheath here. So Cataldo very kindly put a ProStar for us in the femoral artery. And before you put any of these devices, you need to do an angiogram. So possiamo vedere? See. So this is the angiogram. So the entry site is absolutely perfect, and you can see the size of the femoral artery is big enough to take the ProStar or two ProGlides. So having prepared that, we then went up with a catheter, and we got information, hemodynamic information. The left ventricular pressure was 110, as was the ascending aorta. The gradient varied between 10 and 20 millimeters depending on the pressure, and we then did an angiogram. Can you see the angiogram of the aortogram?
The aortogram is clear here.
That's very good. So as you can see, there is a slightly dilated ascending aorta, a very a nice round unobstructed transverse arch, but you can see the two carotid arteries arise very close to one another, and this is a very common variant in patients with coarctation, but we can see a very nice left subclavian artery as well. You can see the two clips which the surgeons left for us very kindly. They're very good markers. He's had a resection with end-to-end anastomosis many years ago, and you can also see the details of the coarctation itself. So if we give you the dimensions that we saw on the angiograms, and they tally very nicely with the CT scan, you can see that the transverse arch is 20, the isthmus just below the subclavian is 17, and at the level of the narrowing is about 12. In terms of the distance that we would like to cover with the stent, it's probably around 30. And the proposal here is to put a stent rather than to do balloon dilatation. I don't think many people would dilate coarctation, especially recoarctation at this sort of age. And the choice therefore is, do we put a covered stent or a bare metal stent? We have made a decision. But if
you have two choices of covered stents. You can either go for the CP stent or you can go for the Advanta. Do you have a preference here?
Yes, we've made a decision on that, and shall we tell them what we've decided? Yes. So we've decided to go for the CP stent, which is a covered CP stent, and we've decided to go for the 45 length because this reduces to about 20%. It's 8 zig, and on a 20 balloon it will reduce by 20%. We can use the Advanta, but I think the Advanta is at the moment having a few problems with cases where there is a lot of recoil, and the initial impression that this was going to be the best stent ever, I'm not sure whether that's necessarily the case on the information that we have. With the CP, we know what we're dealing with. There's a lot of experience, and I think it's now designed in a very robust way. So we have decided to go for the covered CP 45 8 zig.
Joe, you said that you are inserting a 14 French long sheet.
Yes.
Is it a straight long sheet, straight or angled? What is your preference?
So sorry?
Straight or angled?
Is it a straight?
Well, no, this was a Mullins sheath by Cook, and what we generally tend to do is we tend to rub it on the convex side to make it a little bit straight, not completely straight, but to take the shape of the aorta. We also have parked a super stiff wire in the right subclavian artery for stability, because when we did the angiogram, we could see that there was a lot of movement. This is not a very tight coarctation, so we don't want any movement of the stent. And because we're not applying this in the transverse arch, it's important that we park the wire in the right subclavian artery for stability, have a stiff wire, and also have pacing to help us stabilize the stent.
Okay, that's clear.
Good. So if that is the case, then we will go ahead with preparing. Isabella will prepare the stent. This is a pre-mounted 45 centimeter CP stent.
Dai anche questi blu.
And although it's pre-mounted, we generally prefer to use some kind of sheath to go through the valve of the Mullins sheath. There are some plastic covers that you can use, but a lot of people have been used to cutting sheets, and we tend to do that as well. We customize them. You can talk to them as well.
We want to be sure the stent doesn't move.
So they're crimping it a bit more just to be sure.
A little bit more.
So Isabella did the first bit, and Cataldo is doing the bit for good luck.
See a lot of hands. What are you doing?
So they're actually crimping the...
So now we check, and you know that it's well crimped. And now I prepare this tube because I want to introduce the stent without moving it. So I
Just
cut
make sure
this,
that your hands can be seen, Isabella.
12
Isabella?
French sheet.
Can you make sure that
Yes.
they can actually see what you're doing?
And
Don't cover
I
it with your hand.
open with the blade.
Just make sure that they can see it.
Just to be sure that it doesn't be damaged. The stent is not damaged during the introduction. Mi sono tagliata.
Ma perché non taglio completamente? È meglio. Sì. So what I generally do is Isabella has done 4 so that we can get the stent through, but I generally prefer to just cut it all the way through, like so. And like that it gives me a lot more freedom. It goes much more easily, yeah?
Okay.
For those who are not familiar with this, it's
So
kind of
we have
sleeve you
to
put over
flush.
the fabric, because the fabric can get loose from the stent, so you make sure that you're safe when you put it into the introducer.
Yes, absolutely.
Poi inner.
So we've got the sheath, which is the 14 French Mullins sheath, just beyond the coarctation. We have constant flush going through. We've given the patient some antibiotic because we're going to place a device there, and we're also going to have the sutures in the groin, so it's important to avoid having any infection. And we're now getting the 2 balloons of the bib balloon prepared. So there are 2 inflators there. Okay.
The inner and the outer.
So the blue, which is the indigo, is the inner. The O, which is the outer, is the orange.
Okay.
Is that clear?
Yes.
Good. All right. So we're ready to go. We've checked the pacing at a rate of 180, and that drops the blood pressure by more than half. So we're not going to go beyond that. All we need is some stability. So you can see the sheath and the tip of the stent together. And as we go through the valve, it's very important to hold it very, very close. That's it. Okay, stop there. Okay.
So now I remove.
Good. So you can remove this bit here. We don't need it anymore. One of the advantages of the slit is you can pull it easily as well.
What type of wire do you have?
Well, we have an Amplazza super stiff wire, which is exchange length 035, and we've actually parked it well into the right subclavian artery. It's actually in the brachial artery. So we thought that we should place the stent somewhere close to where the subclavian artery is. Remember that the tip of the stent is not covered with Gore-Tex, so even if there's a little bit of coverage, it's not going to occlude the vessel. And we can come back a little bit with the sheath and do some fine-tuning. I suspect that's probably slightly high, but we can just do some fine-tuning. So generally for angiography, these sheets take about 25 cc, so it's a lot of contrast. So what I generally do is I prime the sheath with 10 cc's of contrast, and then when we do the acquisition, I just use saline. Ready to go when you are, acquire. What do you think? It's not too bad, actually.
In my
It's not too
opinion,
bad.
I think you might go slightly deeper because it will shorten a tiny bit, but you're almost in the right position.
Yeah, I would agree. I think it's going to shorten by about 20%. And as we mentioned earlier, the cover of the stent is not as far as the tip. So what we can do, we can pull the sheath back, and then just at the very final bit.
Do you have any worry about those surgical clips? Because I thought this patient had initially had a ductus as well, but it's a bit out of position to have them in that position.
They're not in the position of the ductus. I suspect they were there purely to stop any bleeders. I think he was 2 years old when he had the operation, so there would have been some collateralization. We'll do another angio here, but I suspect that this is going to be a bit too far forwards. We may need to come back a little bit. So we'll just prepare the sheath again. Okay. That's not too bad, I think.
Not too bad, no.
So what we can do, we can actually open up.
Nice.
Yeah, I think we can open up the internal balloon, the blue balloon. So for the inner balloon, we're just going to go on 5 atmospheres. Sì, vai. 5. So, I think if we have it at that point, it may be a little bit too far. What do you think?
I'm still quite happy. Any comments, Andras?
Make a control angio again.
Okay.
And then you can withdraw if it is necessary.
That's fine. I'll do that for you. Contrast this one. Salina. Acquire. It's obviously partly occluded now. It's more the subclavian artery, and I think if you look at where the tip of the stent is, I think it's going to cover pretty much all the subclavian artery. I would come down a few millimeters.
Joe, the cranial clip is a very good marker, and once you open it up, it will move down a little bit because the stent shortens, so I would leave it as it is.
Well, but John is the operator. Joe is the operator, so he has to decide.
Of course, yeah, sure.
Are you going to use that rapid pacing anyway? Because you're almost halfway now.
Yeah, but I think we probably will do that anyway. I feel. What do you think, Isabella?
Well, I think that we can retrieve a little bit, not
Just
a lot, but a
just a
little
couple of
bit.
millimeters.
Yes.
I don't propose more than that. Just come back in relation to the marker, just halfway through the marker, maybe. Yeah. And pull the sheath back a little bit as well. Pull the sheath a little bit back. Okay, I'm happy with that. Okay.
That's okay.
So that's fine. So I think we should be ready for inflating the outer balloon, but I think we need to do the pacing first. So whenever you're ready. Yeah, okay, come in, sure. Fine. Okay, so you can see the screen, please. Let's go. So we're still doing this on pacing. We're up to 2 atmospheres, 3, coming up to 4. So there's still a bit of narrowing at that point. But I think we'll leave it at that. So I'm just going to deflate. You deflate as well. And once we deflate, okay, you can stop. Stop pacing. So let the heart recover a bit. We'll do a little bit of an angiogram here. Put Salina. Salina, sola Salina. Grazie. Ready to acquire? I think it's perfect.
I think it's okay.
Yes. So I think it's in a good position. We've protected the left subclavian. And I think what we'll do is we'll inflate the balloon again because we want to try and abolish that little center portion. If we can't, we probably will use a, depending on the gradient obviously, we can use a high pressure balloon.
Sasha.
But we may well have abolished the gradient just by doing this. Okay.
In between, I can ask the audience who is using rapid pacing during quotation. Hands up, please.
Do you want to, shall we inflate?
And who is not?
You want to inflate without the pacemaker?
No, that's about 50-50.
With the pacemaker?
Yeah, with the pacemaker, but without the inner one, just the outer one.
Yes.
Okay.
Okay.
Okay, so
Stimula,
sì?
Stimula.
Comincia, sì? Sì, ok. I don't think we have enough volume here. We need to possiamo avere un po' di stop pacing.
Looks already quite nice, but there might be a tiny bit of recoil.
Dateci un po' di contrasto di qua. Un po' di contrasto qui. You have to
okay, that's fine.
use this.
Sure. Because we need to get rid of the air bubbles. There, mind the wire. Hold the wire. Okay, let's have some contrast.
Dacci contrasto qui. Just a moment, I want to control the balloon.
Okay, yep.
I think it's
okay.
a bit...
Yeah?
Yes.
Okay, let me just fill in a little bit like that.
Yes.
And
stimola per favore, stimola.
Okay.
Okay.
Screen, please.
You have scream.
Okay.
Which balloon is this?
So this is solely the outer balloon on the bib, and we're up to 5 atmospheres, and I'm just going to come down. I think we've got enough. We'll measure the pressure.
Smetti di stimolare. Aspetta.
Okay. Yeah.
Okay.
So stop there, and let's do an angiogram. With the contrastor. Salina. Okay, and then we'll measure the pressure. Yeah?
Before we have to take the balloon out.
Of course, no, we'll do this. Yeah, sure. Acquire. So I think that looks good. So that looks good. I think we'll take the balloon out, and we'll give you a gradient, and we'll see how it goes.
I think you have to deflate.
Are we not fully deflated?
Yes.
Should be.
Okay.
Should be fully deflated.
Okay.
That's okay. And this one should be fully deflated too. Okay. So Isabella's putting the sheath over the stent, so it makes it easier then to withdraw over the wire. So where's the wire? Here we are. Okay. And the big balloon is coming out very, very nicely. So in a minute we'll flush the sheath. Okay. That's fine.
Okay.
So can we flush the sheath, please? Can we organize the flushing of the sheath?
Sì,
the pressure, la pressione?
Ma it's open, I think. È aperto, no? Il lavaggio. Ok. Allora.
Says, if you can, I'm not sure whether you can see, yes. Let's do the pressure. Can we have the pressure tracing, please? Possiamo vedere la pressione? Sì? Sì, okay. So this is going to be the ascending aortic pressure. We're just going to use the sheath, and we'll do it like a multi-track over the guide wire. You can see that. Can you see the pressure?
We see the pressure tracing.
Okay.
Yes.
So Isabella's withdrawing, keeping the wire in position. So she's at the level of the upper end of the stent at the moment. She's now halfway through the stent, and she is now below the stent, and there's no gradient whatsoever. So I personally would not push this with a high pressure balloon. I think I would leave it as it is.
No. I think it's a good result, so we don't do anything else.
There's nothing on the angiogram to give us any concern, but I think we've achieved what we wanted to achieve, and quite happy with things.
Joe,
Yes.
there is a question from an audience.
Yes, of course.
Hello, Joe.
Yes.
Good case. It's Joachim Nero. Very nice case. However, the patient is under general anesthesia. He's a big patient, as you told. He's 36. I don't think you will ever want to come back unless. So I think physiologically, I would not accept this minimal diameter at the stent as as a final result. I would probably die. It's a covered stent. It's a very stable stent. It's not going to move. I don't think there's much to lose in redilating with a high-pressure balloon, and then you're pretty much sure it's not going to have hypertension on exercise, which you know is going to have with this configuration of a stent. If it was a younger kid, and we know we would need to come back, it's a very good final result. But this is you want it to be a final result.
Sure. I agree, thank you. I think what you're also seeing though is the post-stenotic dilatation, which gives you the impression that there is still narrowing, but in fact the diameter of the isthmus is certainly better than what it was, and we've got no gradient. I'd leave it up to Isabella to decide, but I would support leaving it as it is at the moment.
Yes, I agree with Joe. I don't want to have complications, and I don't want to do more than it needs now. If there will be the indication, we can repeat the dilatation after.
I agree, and I think a dilatation is a lot more straightforward than having to put the stent, and I think there's never a final procedure with these things. You can get ingrowth stenosis, you can get stent fractures and so on. So I hope we've achieved a good result without any complications, and that's the aim of the procedure. So I think what we'll do is we'll leave it for Cataldo to show you how he's going to finish up with the ProStar closure, if you have time, that is.
We don't have time.
Okay, that's fine.
Joe.
Yes.
Joe, unfortunately, we have still one presentation to go, so we have to leave you.
All right, that's fine.
Okay.
That's fine. Any questions?
It was a perfect job.
Thank you.
Thank you very much.
I will see you
Thank you
later.
very much.
Thank you.